Good afternoon, good evening, and good morning, everybody. Welcome to the VBU Virtual Bariatric University, episode number 26. And today we have Sleeve Plus Bariatric Metabolic Operations. I am Dr. Mohit Bhandari, bariatric and metabolic surgeon and robotic surgeon from India, co-hosting this show alongside Professor Matthias Fobi, who is the clinical director at Mohit Bariatric and Robotic Surgery Center. At the outset, I would like to introduce our stellar faculty. We have Kasama Kazunori from Japan. Kazu is a great friend. I have great relationship and camaraderie with him since last so many years. He is the president of Asia Pacific Metabolic Bariatric Surgery Society. And it's an honor for us because we also belong to the IFSO APC region. Kazu is currently director of Weight Loss and Metabolic Surgery Center at Yotsuyu Medical Cube, Tokyo. As I said, he is the president of the IFSO Asia Pacific chapter, immediate past president of Asia Pacific Metabolic and Bariatric Surgery Society, executive board member of Japanese Society of Endoscopic Surgery, and the chairman of International Affairs Committee of JSES. He's at the executive board of IFSO and also at the executive board for Japanese Society for Treatment of Obesity. Welcome, Kasama, to the Virtual Bariatric University. We have another great friend, Tarek Mandy from United Arab Emirates. Tarek is a professor of endocrine surgery and metabolic surgery in Egypt at Mansoura Faculty of Medicine. He is also affiliated with Sharjah University in UAE. I have been to his university and his hospital, which he established to deliver a lecture 2 years back, and enjoyed his hospitality. Tarek has focused most of his research on physiological mechanisms by which different bariatric and metabolic operations work, and also their effects on diabetes. He's one of the first surgeons to support the concept of bipartition and also the functional restriction instead of mechanical restriction. He also supports the idea of bipartition procedure as the future of metabolic surgery. He developed the single anastomosis sleeve ileum bypass and has trained surgeons all across the world in that procedure. Welcome, Tarek. We look forward to have you and listen and learn from you and from your wisdom on this show. Dr. Aureo de Paula from Brazil. Aureo is a great surgeon. I would call him as a maverick, more than a tremendously gifted surgeon. He is a maverick surgeon. He's somebody who I appreciate so much for his surgical skills and have a lot of respect for him. Aureo is the founder of ileal interposition surgery, one of the most tough bariatric procedures, but one of the most scientific bariatric procedures. He is from South America, from Goiânia in Brazil, extremely skilled. And before starting ileal interposition surgery, he was a big authority in transhiatal esophagectomies for Chagas disease. Welcome, Aureo. We have a lot of surgeons from India and across the world trained by you. And I have no words. I'm speechless when I watch you operate. From Czech Republic, we have Martin Fried. Martin is the head of OB Klinika Center of Treatment for Obesity and Metabolic Disorder in Prague, in Czech Republic. He was the professor of surgery and the first faculty of medicine, Charles University in Prague, executive director of 2004 IFSO European chapter, founding member of IFSO, president of IFSO in 2001 and 2, founding member of International Federation of Surgical Obesity in 1995, and a member of European Association for Study of Obesity. Presently, he is a vice president of Czech Society of Study of Obesity. Welcome, Dr. Fried. I have had a couple of invitations from Martin. Unfortunately, that conference could not take place, but we did it virtual, and I had a great honor of participating in his show. From Greece, we have Professor John Melissa. He's currently the director of Department of Bariatric and Metabolic Surgery in IOSO General Hospital in Athens. Dr. Melissa graduated as a medical doctor from Athens University and subsequently worked 8 years in Johannesburg returned to Greece as an assistant professor in University of Crete, and then became the director of the bariatric unit. He joined the IFSO in 1996 and became the president of the 6th World Congress in 2001. He elected and served as the president of the IFSO in 2006 and 7. And since then, he's the member of the board of the trustees. He's now the director in the scientific board of European Accreditation Council for Bariatric and Metabolic Surgery, research interest, obviously, in bariatric and metabolic diseases. Professor John Melissa, it's an honor to have you here on the show. And you are coming for the first time to this virtual platform, which myself and Professor Fobi is hosting since last 1.5 years now. I hope you enjoy and we learn more and more from you. We have Dr. Bassem Safadi, another friend from Lebanon. Bassem is chair of surgical services at Amman Hospital in Qatar, in Doha. He's a well-known figure in bariatric and metabolic surgery in MENA group. He graduated from American University of Beirut as a faculty of medicine and completed his surgical training in the United States, occupied academic positions at Stanford, AUB, and was a chair of the Department of Surgery at the Lebanese American University. He's currently the president for the IFSO Lebanon chapter. It's an honor to have you, Bassem, and I hope you throw some light on this bipartition and sleeve plus procedure. From India, we have another great teacher, Dr. Surendra Ugale. Dr. Ugale is a director of bariatric and metabolic surgery at Kirloskar Hospital and a visiting professor at KL University in Belgaum. He's a very passionate teacher of laparoscopic surgeries in 1991 and was the first person to start laparoscopic surgery in South India. He, along with his team, is the second in the world to start the laparoscopic ileal interposition and has trained multiple surgeons, various countries like Turkey, Georgia, Iran, Mexico, and Russia. He introduced the diabetes scoring system in 2013. His work is mostly focused on metabolic surgery and diabetes surgery and has over 28 publications in the field of how to treat diabetes by using metabolic surgery. Welcome, Professor Ugale. It's an honor to have a teacher like you on this platform. At last, myself and Professor Fobi, we welcome all of you on this great show. And I hope that it creates that difference in your regular knowledge about bariatric metabolic surgery and change your perspective towards various different procedures. Now I'd like to invite Dr. Bassem Safadi, Aureo, and Martin to moderate the first lecture session. I would also like to invite Professor Kasama Kazunuri to present his lecture on the sleeve plus RNY or loop DJB. Kasama.
Thank you, Professor Fobi and Dr. Bhandari for kind invitation. It is my pleasure to talk about the sleeve plus procedures, especially sleeve DJB with LUNY and loop fashion. This is my COI, and this is a case mix disclosure. In Japan, only sleeve gastrectomy is covered by national insurance, so that the number of sleeve gastrectomy recently is very increased. So sleeve plus procedures is based on sleeve gastrectomy and add some bypass procedures. The term of sleeve plus procedures was used by the Shiken Huan in Taiwan. And the most effective procedures among ISO recommended one is the BPDDS and the SASS. So BPDDS and the SASS is kings and queens, but the king and queen sometimes bring something evil. That is a protein malnutrition. So this is a map of protein intake per day. So in comparison with the United States, Asia has much less intake of protein. In Japan, we just have a 2/3 of the United States, and India and other Asian countries is just less than half of the United States. So too much hyperabsorptive procedures like a BPDTS are not recommended in Asia. In 2007, I started sleep DJB as a combination of Roux-en-Y gastric bypass and sleep gastrectomy. The size of the bougie is the same with sleep gastrectomy, and the BP limb is 1 meter and A limb is 1.5 meters in a Roux-en-Y fashion. But recent, my sleep DJB is a BP limb is 1/3 of the total length of small intestine, approximately 2 meters for Japanese patient, and the A limb is a half of BP limb. So that the common channel is a half of the total length of the small intestine. And we also have the another reconstruction way of DJB. That is a loop DJB. So Roux-en-Y DJB is an alternative to BPDDS, but a long common channel and a slimmer gastric tube. That we can avoid bypass stomach so that so-called Asian BPDDS. So loop DJB is the same concept, and the second one and the Wei started in the loop fashion. It's something like Asian SASS. So I'd like to talk about the outcome of DJB, the long-term results of DJB. We already published the 5-year results of sleep DJB for diabetes patients. So this is a result of change of BMI. It started from 38.5 and then at 5 years, 28.4. So that the percentage of total weight loss at 5 years is around 30%. And the remission rate of the diabetes is 72.7% at 5 years. So we need to talk about the low BMI patients with diabetes, because the majority of our diabetic patients is BMI less than 35. This is our result of 5 years. It started from 32, and then the BMI goes down to 25 at 5 years. This is a change in glycemic profile. So 91% of insulin user can stop the insulin after surgery. So that we need to compare the DJB, sleep DJB to sleep gastrectomy alone. This is a result in Japan, the Menssas study, and compare the anti-diabetic effect between sleep DJB and sleep gastrectomy. So diabetes remission in overall patients is quite high in both groups. Was 80% in both groups. It seemed it's almost the same, but we have sub-analysis according to the severity of diabetes. We use the ABCD score. The lower the score, the more severe diabetes. So if the patients have the ABCD score more than 6, which means a mild diabetes, the remission rate is quite high in both groups, almost 95% of the remission rate in both groups. But for the severe diabetes patients, the sleep DJB provided much better remission of diabetes. Especially for the insulin user, the sleep DJB is much better remission rate in comparison with sleep gastrectomy alone. So we need to compare sleep DJB to sleep Roux-en-Y gastric bypass. So this is a very nice study from India, Flavin Raji published RCT between LNY and 3-DJB. The operating time is longer in 3-DJB, and the weight loss and diabetes remission is the same in both groups. So 3-DJB, 3 gastric bypass is the most effective and the best for Asian, but we cannot forget gastric cancer. So gastric cancer is the 1 million cases per year worldwide, and the fifth most common malignancy in the world, and the third leading cause of cancer death. So in Asia, we have much more cancer in comparison with other regions, especially our region, Eastern Asia, China, Korea, and Japan occupied more than half of the worldwide gastric cancer. So we have published the case reports of gastric cancer successfully treated with ESD after 3-DJB. And the gastric cancer ratio after gastric bypass in Asia, we usually published that 1,000 case, 1 in 1,000 case, and in China, 1 in 500 case. So this is a ratio that I cannot neglect. And the advantage of 3-DJB over gastric bypass is less ulcer and less stenosis. Our ratio of marginal ulcer is 0.5%, and the stenosis is 0% in our series of 3-DJB. And the 3-DJB provides less malnutrition, especially vitamin B12 deficiency. So this is the result of the 3 groups, sleeve gastrectomy and gastric bypass and 3-DJB at 5 years. And the gastric bypass showed less hemoglobin in comparison with preoperative status. And this is a change of our serum folic acid. Of course, in 5 years, our sleeve gastric patients don't take any supplement, but our bypass patients, we recommend to use supplement for bypass procedure like 3-DJB and the gastric bypass patients, so that the folic acid increased in the bypass group and also 3-DJB group. Using the supplement, the gastric bypass tend to decrease vitamin B12 in the long term. And the 3-DJB provide less dumping and less glycemic variability. I think it's a bile loss preserving effect. So the more glycemic variability, the more vascular complication. So that the glycemic variability is a problem in gastric bypass. So less than 3+ procedure like PPDS and SASS. And the 3-DJB provides bile loss preserving effect. So less dumping, less ulcer stenosis, less glycemic variability, and less malnutrition. But 3-DJB has more guard and longer operating time. So to reduce the operating time, the loop is accepted. The loop is easier and the shorter operating time because the less anastomosis and the less mesenteric closure. And this is a result of loop DJB by Wesley group. And this is a comparative study between 3-DJB and LNY. So longer operating time in 3-DJB, but the weight loss is a little bit better than Lu-NY, and the resolution of comorbidity is better than Lu-NY. And also, this is a result of a BMI less than 35 from CK1 group, longer in SWIFT-DJB in the operating time. The weight loss is similar and the resolution of comorbidities are similar. And this is a 5-year result for SWIFT-DJB, and total weight loss is 22.5 at 5 years. It's a little bit less than our data, but almost same. But the de novo guard is a problem of the SWIFT-DJB. So in comparison with WHG and the CK loop DJB data, Lu-DJB, Lu-NY DJB outcome of weight loss and DM remission is almost same. The loop is easier and the shorter operating time. But my concern is the viral exposure to the stomach. But recently, I also do a loop DJB, and the viral exposure to the stomach is very easy to convert into Lu-NY after loop DJB. So in conclusion, the SWIFT-DJB is as good as Lu-NY gastric bypass in terms of weight loss and the diabetes remission, and can avoid some drawbacks of Lu-NY gastric bypass and BPDES in Asia. Loop DJB is easier and accepted. So SWIFT-DJB procedure will be one of the choice in Asia. Thank you very much.
Thank you, Dr. Bhandari, on?
Yeah.
Go ahead.
Thank you, Kasama. It's a nice presentation. I have 2 questions for you.
Yes.
First question is that, I know that you belong to a region, and specifically China and Japan, where there's a very high incidence of these malignancies. So it makes sense not to have a remnant. But at the same time, from the mini gastric bypass data which has come, loop anastomosis does not show any higher incidence of gastric cancers or esophageal malignancies. And also, although I agree that it's a very short follow-up of around 8 to 10 years, and we do not have a study of 30, 40 years. But considering the fact that bile in most studies have not been able to prove as carcinogenic, would you not feel that compartmentalizing the intestine is a bit too much and takes more time? Number one. Number 2 is that particular anastomosis which you do with the duodenum. We have been doing SIDEs, and long back in 2010 and 11, I was doing a Roux-en-Y DJ bypass where I used to anastomose with that first part of the duodenum. Most times that anastomosis was technically very difficult. So why do you think that, considering that we have very less data about malignancies and the complications of bile reflux, we should still be compartmentalizing intestine and doing a Roux-en-Y like you do? What's your take on that?
Actually, thank you for the question. Actually, our data from the National Cancer Center in Japan, they have many data regarding gastric cancer. And they reported that 30 years after B2 reconstruction, the cancer ratio around the marginal is more than Roux-en-Y and B1 reconstruction. So that maybe in 10 years, five or 10 years, they don't have any difference, but there is a possibility after 30 years of surgery, we have more gastric cancer at the remnant stomach, the anastomosis. So what I need to think about is we do a surgery on the younger patient than the cancer patient. Actually that 50 years ago in Japan, we have a lot of gastrectomy for the ulcer patient. For such kind of patients have more gastric cancer after B2 reconstruction because they live longer than cancer patients. So that my concern is for the doing loop or B2 reconstruction for if we do a younger patients like 20 or 30s, there is a possibility that the patient may suffering from the malignancy in the 30 years after surgery. This is our history from gastric cancer.
Thank you, Kazu. We have it's a very fine explanation, and I think that's the reason why still most, even the IFSO position statement, which has been recently updated, and they said that yes, there is no concern about bile reflux presently, but all of them said that we have a very shorter follow-up in terms of loop reconstructions, and we don't know what's going to happen 30 years down the lane. Thank you, Kazu. Excellent lecture, excellent presentation. I'll go through your lecture again and again and learn a lot from it. Thank you so much.
Thank you. So I need to add one thing that one of the good things for BPD, the DJB is we preserve the pyloric ring, so that maybe it's a less viral exposure to the stomach compared to the usual the B2 reconstruction after gastrectomy.
Yeah, Kazu, I kind of agree with you, but if you talk to Dr. Fobi, we saw a lot of surgeons doing DJBs and destroying the pylorus. In short, they were doing something called as a mini gastric bypass in the grab of, you are an excellent surgeon. You dissect that duodenum, you make a nice 2.5 to 3 centimeter of a duodenal cuff. You make sure that that anastomosis does not destroy pylorus. But I have seen surgeons doing anastomosis with the pylorus, or just above the pylorus, and they destroy the pylorus completely. So what I mean to say is that yes, obviously, if you have preserved pylorus, fantastic. That definitely decreases the bile reflux. And considering the fact that Billrod 2 reconstruction and D2 gastrectomies have such kind of history, I agree. But there are technical challenges for surgeons who are looking at an easier procedure. And number two, I would seriously like surgeons like you to criticize those surgeons who, in the grab of doing pylorus preserving procedure, destroy the pylorus and demonstrate it to the audience. Thank you. Thank you so much.
Okay, thank you.
We'll move on to the next moderator. At this time, we're going to ask Dr. Safadi.
Yes. Thank you, Dr. Fobi. Thank you, Dr. Bhandari. And it's my pleasure to introduce Professor Tarek Mandy, who is a well-known figure in metabolic and bariatric surgery in the Middle East. Dr. Mandy is a professor of endocrine and metabolic surgery at Mansoura University Faculty of Medicine. He's also affiliated with Sharjah University, UAE, as a clinical professor and the head of surgery. He is an innovator, and he's developed the single anastomosis sleeve ileal bypass, the SASS, and has trained surgeons all around the world on how to perform the procedure. And he is going to talk to us today about SASS, the bariatric metabolic operation indications and outcomes. Welcome, Dr. Tarek.
Thank you, Mr. Chairman. Thank you, Dr. Fobi, Dr. Hendra, to give me this support to present my talk about SASS bipartition, bariatric metabolic operation, indication and outcomes. I didn't have any disclosures, and my case makes disclosure is 40% sleeve gastrectomy, 30% SASS bypass, and 15% rural gastric bypass, 10% reservation surgery, and 5% mini gastric bypass. If you ask me, since 6 years, is 60% of my cases is mini gastric bypass. But now they change mini gastric bypass because less to 5%. We know that metabolic surgery is now the well-established concept, which originated from diabetic remission from bariatric surgery. And all of us, we know that metabolic surgery means we are going to disturb the anatomy of the gastrointestinal tract, disturb the physiology of the gastrointestinal tract, to get a benefit in one hand and to get a complication of the other hand. And we know there is controllable and uncontrollable complication. Uncontrollable complication, as in the scopular operation, we can control the complication despite we supply external vitamin and protein. And the ideal metabolic operation, from my view, must be easy to do it. Bariatric surgeon can do it with less learning curve. And residual metabolic syndrome in the form of weight loss, remission of diabetes, hypertension, hyperlipidemia, and sleep apnea, and controllable nutrition deficiency. And also, according to the GCI guidelines nowadays, our patient must select which type of operation can do it. At the same time, it is right of our patient at any time to ask us to convert to normal anatomy. I think it is the right of our patient and must be ready if your patient asking to go again to the normal physiology. We have a lot in the bariatric market, a lot of operation, and all of this operation really have good weight loss and good remission of the comorbidity in the form of diabetes and hypertension, hyperlipidemia, or sleep apnea. But the current metabolic operation create another disease to treat the metabolic syndrome. And some procedures place obstacle against food ingestion through the use of narrowing anastomosis, or sometimes use of procedures. And this is dysphagia, vomiting, stasis, vaginitis. And there is some operation, some surgeon do tight sleep to induce the vomiting, which increase the excessive weight loss. Also, the exclusion part in malabsorptive surgery leading to bacterial proliferation and bacterial translocation to the portal system, which is linked to hepatic decomposition. Especially, our patients have some degree of non-alcoholic fatty liver disease. The most powerful operation is coronary operation, the malabsorptive, but with weight loss around 90%, remission of diabetes around 95%, but all of this operation leading to protein, nutrients like calcium and folic acid, and uncontrollable complication. And all of us know that now the human diets become unnatural, hypercaloric, urine fiber, redigested by cooking refined, and extremely easy to be absorbed in the proximal portion of the bowel, creating a peak of nutrient absorption. But the distal bowels tend to have less absorptive work, which would cause lengthy production of GLP-1 and BWY, so latent satiety, and also increase uncontrollable of glucose in the blood. So in metabolic syndrome, we have imbalance between the activity of the regional part and the ileal part. We have hyperactivity of the regional part and ileal hypoactivity. In 2002, Sérgio Santoro in Brazil had new theory in metabolic disease. His theory, we need to make adaptation of the gastrointestinal tract to overcome the change in our diet nowadays and to control the metabolic syndrome through make a new balance between the upper gastrointestinal tract and lower gastrointestinal tract. For this reason, he has sleep gastrectomy with transabdominal hypertension. Sérgio Santoro tells us about why I'm going to exclude the duodenum and upper part of the region to induce good weight loss and remission of diabetes, and they have the same results if you are going to make pipe partition, to make two openings, one direct to the ileum to push undigested food and decrease the amount of the food which is touching the duodenal regional part. According to Deschamps' theory, when we decreasing the amount of the food to the duodenum, this will decrease or control the secretion of GIP. So we induce sleep gastrectomy here to induce gastric satiety at the same time intestinal satiety, because we know gastric satiety is dependent on the side of the stomach. We have sleep gastrectomy, which is function restriction, and also have some hormonal because decrease the ghrelin hormone in the first year. So we induce function restriction, and in spite we push the food through the duodenum, through the ileum here to induce early secretion. At the same time, with secretion of GIP, we secrete the GLP-1B. And you have also a very nice perspective randomized controlling trial comparing the transient bipartition, sleep-restricted transient bipartition with lifestyle management. And he finds that sleep-restricted transient bipartition has a better metabolic and cardiovascular profiles than the medical treatment of the obesity. So the problem is the ileum, ileum hypothesis, because we need secretion of GLP-1 to make a balance with the GIP secretion. So the same, we have functional restriction, decrease the brain hormone, and we bring the ileum to make the balance between the two. SASS A bypass is a modification of sleep transient bipartition to make it easy to do it and have the same concept of one anastomosis mini gastric bypass, because I'm an expert for mini gastric bypass. So I know the bile is the stomach, not a big deal, but the bile of the esophagus is a big deal. So we can do the same operations, the same concept, but through one anastomosis to make the ileum to be anastomosis to the antrum of the stomach. So also we have two ways, and we push the undigested food at the same time the food passes to the duodenum. So we have gastric satiety and intestinal satiety, early intestinal satiety. SASS A bypass, it is adapted gastric channel to reduce the ghrelin through the function restrictions through sleep gastrectomy, and we make the L-cell nerve to the stomach, so touch early the ileum to induce secretion of GLP-1B. It's easy and safe thing when anastomosis. And we don't have any excrete segment. We don't have bacterial translocation, contact translocation. All the food touch each millimeter of the gastrointestinal tract. Also, we have total endoscopic access. You can access to the duodenum through the endoscope, through the biliary system. We have controllable nutrition deficiency. The antrum and the biliarus is reserved, and we don't have any processes, have any mechanical restriction. Also, it is very flexible procedures in a patient with body mass index 30 and metabolic diabetes, hypertension. You can do it with wide stomach, and if the patient has severe morbid obesity, we can the stomach more smaller. Also, it drains the sleep stomach, so reducing the high intragastric pressure of sleep gastrectomy, and the incidence with this operation is very low because we have low intragastric pressure. Also, it keeps the stomach in the right position, avoiding coiling in the sleep gastrectomy. So what is different between sleep transient bipartition and SASS A bypass? It is easy to do one anastomosis, no mesenteric defect. We have the same results. And also we have easy exit strategy. At any time your patient asks you, please convert me to the normal analytic. You will take 10 minutes only, because we'll put you stapler here to make separation between the antrum and the ileum. So the neuroanalytic come back again in 10 minutes, just 10 minutes only. This is the right of your patient at any time to ask you to convert to the normal analytic. Also, all of our patients, we follow it by annual endoscopy, and we didn't find anything between the sleep transient bipartition and the single SASS A bypass, because we know the bile in the stomach, it is the usual event, maybe having sleep gastrectomy and having also the normal anatomy. Our excessive weight loss is around 80–50%, and this is a glycemic and lipid profile, decreasing all metabolic syndrome in the form of HbA1c, triglyceride, and fasting glycemia, And also here, the remission of our diabetes is a duodenal scoliosis operation around 95%. I remember since 4 years when I present our data, Dr. Scupinaro tell me, do you mean that this operation as my operation, Scupinaro operation? I tell him, yes, sir, I have 95% as you remission of diabetes. This is where you see them by chemical profile and pre and post operative. And we know here there is improvement in the gamma glutamate transaminase and the LDT post operative. Also, this is a nutritional value before and after SASS bypass. You must know that all of our patients have preoperative iron deficiency anemia. And if you notice here, all our patients have still supply of iron, so the iron become a normal one. And also the albumin, which is a very important, as the albumin after 2 years is 4.1. This is the first publication about the effective SASS bypass retrospective cohort study. And it's also another to study this MDCCs in Mansour University about the effective SASS bypass in 2 different centers, Radiology Center and in surgical department. And also, this is another study from Shams University about effective SASS bypass. Also, this is the MDCC and supports the effective SASS bypass. And this is another study from Iran about 1 year for our bypass. And this is a study from India, from Ammar, and he has different lenses for the ilium, 2.5 meter from the iliocecal web and 3 meter and 3.5 meter, and we find 3 meter is best one. And this is another study from Mexico, also have a good result for SASS bypass. And this is another study from Bahrain also, using SASS bypass to treat the metabolic syndrome, and is a good results. And this is a comparison between single anastomosis aerial bypass and sleeve gastrectomy, that's mentioned multi-center study. And he finds that there is the SASS bypass is superior in result in remission of diabetes and weight loss. And this also another study is comparing the sleeve gastrectomy with SASS bypass. And this is a comparative study between laparoscopic single anastomosis and mini gastric bypass. And there is a good result of SASS bypass, especially in nutritional deficiency. And this is also comparative study between sleeve gastrectomy and one anastomosis gastric bypass and SASS bypass. And based on the retrospective review of our data, the SASS bypass was associated with more reduction in the body weight and body mass index, higher and total weight loss percent, weight loss beta improvement, and the beta improvement in diabetes. And this also comparing the Roux-en-Y gastric bypass with long bilipancreatic rim with SASS bypass. And we find that SASS bypass has good improvement in comorbidity, and Roux-en-Y gastric bypass with long BBL have some decrease in the level of the albumin and iron and SASS bypass. And this is a multi-center analysis from 7 centers around the world, from Egypt, UAE, and Kuwait, and Norway, Germany, and Portugal, and Turkey. And all of this, the result of this multi-center study proves the effect of SASS bypass as a good metabolic operation, especially in comorbidity, especially in the remission of diabetes, and also to treat the GERD. As my friend in Munich, Michael Kramer, used Roux-en-Y gastric bypass, Roux-en-Sassy bypass to treat the GERD after sleeve gastrectomy. We have very nice here, 60-80 cases with GERD after sleeve gastrectomy, and he done Sassy bypass for them, and with improvement of all symptoms of GERD bypass after GERD symptoms after Sassy bypass. This study from Italy for use of Sassy bypass after failed sleep, and this another study to use Sassy bypass after sleep gastrectomy as reduced surgery for failed or with regain after sleep gastrectomy. And this very nice study from Kuwait from Dr. Mohammed talking about use of Sassy bypass as a good option for weight regain after sleep gastrectomy. Also, this is another one to use the Sassy bypass, and the comparison between Sassy bypass and sleep gastrectomy after failed intragastric balloon. Also, you can use the one option as reduced surgery. And in 2019, with Dr. Fobi and Mohit, also we make standardization for all bariatric and metabolic procedure to get standardization of our technique here. So metabolic operation, sleep gastrectomy is not enough alone to treat the metabolic operation. And it didn't switch, it is too much to use it with uncontrollable diabetes. But Sassy bypass have the same results of as uterine switch, but with less malabsorption and good metabolic change with no exclusion at all, and with the complication of the exclusion. Nowadays, Sassy bypass went global all over the world now.
Hi, it's Evie. I am having my anniversary today, 1 month, post-op Sassy bypass.
We are happy to encourage more and more surgeons to do it, but still we have some discriminating result of Sassy bypass in different countries. We have 2 centers in Cairo, and 1 center if we have not good results of Sassy bypass. We invite our colleague from in Riyadh to visit us in Dubai and present her cases about why he have a bad result with Sassy bypass. And we discover his operation is not Sassy bypass at all. He do anti-prosthetic anastomosis and the big anastomosis with the body, not with the antrum. And the restorative anastomosis is more than 3 centimeters, up to 6 centimeters. And also the 2 centers in Cairo have a bad result. We discover a lot. I will present now. All usually their patients have failure to resolve this and hypervolemia, severe anemia, even lower limb, liver insult, and even liver cell failure in some cases with this very bad results. So we must know this is a cornerstone of cystic hypertension. You must have good sleep, wide incisura, and the complete excision of the fundus. And the anastomosis must be to the ear, not to the jejunum at all. At least 3 centimeters from the ileocecal valve, as mentioned by standardization in India in 2019. And you must learn anastomosis to be with anterior wall of the antrum, not posterior wall. And the rest of the anastomosis must be less than 3 centimeters and must be isogastric. This is very important, and this is a cornerstone of cystic hypertension. So you must have good sleep gastrectomy with wide incisura. This is very important because if your patient have tight sleep and narrowing incisura, we have repeated vomiting, and this will lead to severe nutrition deficiency. It disturbs the quality of life of your patient. And also, you must measure from here, from the ileocecal valve, not from the treated ligament, because you need to make anastomosis with the ear. The problem is the ear. So if you make it from the jejunum, it's not Sassy bypass at all. we must know the average diameter of the small intestine is around 7 meters. Reported case 4 meters and reported case also 12 meters, but the average is 7 meters. And the 2/5 is jejunum is around 280 centimeters, and the ileum 3/5 of the all small intestine. So it is around 4 meters and 20 centimeters. So if you make your anastomosis with 3 meters or 3.5 meters, it is safe, and this anastomosis will be in the ileum. Also, we need proper measuring of the ileum because you are going to measure from the ileocecal valve. So it is good to put some marker in your grasper for proper measuring of the ileum. Also, your anastomosis, this is a fatal mistake usually done in Cairo. You will make the anastomosis with the posterior wall of the stomach. And this will make the ileum, it is the posterior wall of the stomach after anastomosis, will more dependent. And also, you notice here, he puts the stapler towards the body. So we will make anastomosis with the body, not with the antrum. And this is another mistake. We'll make complete diversion and convert this operation from bipartition to complete diversion. So you must do your anastomosis with anterior part of the antrum, and you must push your stapler towards the pylorus, not toward the body of the stomach. And also, your anastomosis must be 3 centimeters or less than 3 centimeters. This is very important when you are going to do your anastomosis. Anterior wall is the antrum, not in the body. Your tip of stapler towards the pylorus, and your anastomosis is around 3 centimeters. Other factor which have discrepancy results, length of the ileum less than 2.5. One of my colleagues makes the length of the ileum 1.5 from the ileocecal valve, and all the patient has severe nutrition deficiency, and some patient have liver circulation. Also, anastomosis just near to the pylorus, not 6 centimeters, as mentioned by Dr. Fobi in our organization of this technique, but to be antiperistaltic. Also, we need good postoperative, and the dietitian rule is very important to control the diet of patient postoperative. So, according to the standardization of our technique in India in 2019, we have the distance of sleeve gastrictomy away from the esophageal gastric junction and so 1 to 2 centimeters, and the width of sleeve 3 centimeters. The distance from the pylorus to make your opening is 6 centimeters, and the width of the gastroileal anastomosis is less than 3 centimeters, and the length of the gastroileal measured from the ileocecal valve is 3 meters, and the volume of sleeve around 150 to 175. So if you see these pictures, the gastrography study in the second day after surgery, you will see 2 ways, one through the pylorus and another one here. This is the normal way through the anastomosis, and this from pylorus. This is good operation. But if you see the gastrography pass direct only to the your ileum only without any gastrography pass to the duodenum, you must go again, take your patient to OT and revise your anastomosis and make your anastomosis less than 3 meters. Thank you for your attention, and I'm so happy to receive your comments and questions.
Professor Safadi.
Yes, thank you, Dr. Mandy, for this enlightening lecture. I'm going to stop a little bit on the issue of standardization that you raised, and you said that there are other hospitals, other centers that have poor results. Now, when we heard your presentation, you mentioned that you have at least 3 meters of gastroileal limb. Is that across the board, regardless of the total length of the small bowel? And then I just have a couple of comments, just so we understand this procedure a little bit better. So I kind of position this procedure between the OAGB and the SADI procedure. In the OAGB, at least we have the stomach preserved in case there's any problem, that we have the stomach to reconstruct. Whereas in the SASS, we've lost the stomach. And in comparison to the SADI procedure, we've maintained the pylorus. So the advantages of maintaining the pylorus are preserved. I still don't understand quite well where the SASS sits between these two procedures, and explain to me a little bit more of how this procedure induces weight loss. Is it by hypoabsorption? Is it malabsorption? Is it hormonally, it lets the patients eat less? Where exactly is the strength of the SASS? And my last comment is, we have three openings, the pylorus, the efferent, and the afferent limb. How do we guarantee where the food is going from which part? Is because I noticed on the endoscopy picture you showed, as if one of the anastomoses, the stomach got really small. Have you had long-term follow-up on your patients to see if that gastroileal anastomosis stays patent long-term? And again, thank you for innovation. I think we need to better understand these procedures, and your work is definitely shedding light on some things we don't understand.
Thank you, Professor Safadi, for your comments. And I will start with the first one. You mentioned that you'll take 3 meters from the ileocecal valve in spite of the length of small intestine. I mentioned here the average length of the small intestine is around 7 meters. And you know, 2/5 is jejunum and 3/5 is ileum. So if the patient even have 12 meters or even have 4 meters, I think when you are saving 3 meters, it is very nice. About, we will understand this point when we are going to know what is the mechanism of weight loss in a patient with bipartition, especially in SASS bypass. You told us now the SASS is between SADI and mini gastric bypass. This is not true, because the concept is different. The concept here is we are going to bipartition, not for exclusion. I mean, the food will pass in each 1 millimeter of the gastrointestinal tract. We don't have excluded segment at all. The aim of this operation is to stimulate the lower gastrointestinal tract at the same time with the upper gastrointestinal tract. We need to push some undigested food to the ileum at the same timing with when the food passes to the duodenum. So we'll stimulate the upper and lower gastrointestinal tract at the same time. For this reason, we are going to make a balance between the duodenojejunal activity and the ileal activity. We need GIP, and we need also GLP-1 and BWY, because GIP is controlling glucagon and the insulin. And we need GLP-1 to induce satiety, intestinal satiety, and the sleep gastrectomy will induce the gastric satiety. So we have the two satiety at the same time. So the mechanism.
Yes. Do you mind if I interrupt here for a second, just to ask you a question, because I think, has anyone studied the caloric intake comparing the SASS versus, let's say, DS or OAGB? Do we have quantification?
No. I discuss what is the mechanism, because this is a physiology. You know, we have two satiety, one gastric satiety and another one intestinal satiety. Intestinal satiety start when the food touch the lower part, the ileum, to stimulate the L cell to secrete GLP-1 and BWY. At this point, the intestinal satiety will happen. This physiology, this is not my information, this is physiological information. And the gastric satiety is dependent on the gluttony, is dependent on the size of the stomach. So if we decrease the size of the stomach, we'll make gastric satiety early. At the same time, when we push undigested food to the ileum, he will touch the ileum wall and stimulate the L cell to secrete GLP-1 and BWY. This is a mechanism how the patient have weight loss and has the diabetic remission. This related, we are going to the physiology, the normal physiology of our patient. When the food in the past, when we are taking the normal healthy food, the food passed through the upper gastro and going to the lower gastrointestinal tract, because the food has cellulose, so you can stay in the lower gastrointestinal tract, stimulate the L cell. But nowadays, we have refining the food, we have digested food, and completely absorbed it in the upper gastrointestinal tract. For this reason, we have hypoactivity of the ileal part, and we have hyperactivity of the duodenal part. So we need adaptation for the new food nowadays. We are saying the food at the same time, one through the normal way, through the pylorus, and the other one to the gastroiliac anastomosis. We need some undigested food to pass to the ileum to induce this mechanism. For this reason, there is a big difference between all of exclusion surgery and bipartition. The exclusion is defined completely in malabsorption syndrome and rapid passing of the food to the lower part. If you have
I think you explained that very well. I just want to make sure we're okay with time. Just wanted to wait a signal from Dr. Fobi.
Yeah, I think we should move on to the next lecture and then we can discuss.
Thank you, Dr. Mandy. Thank you.
Okay, thank you.
Aureo, it's your turn. Aureo? Is he on board? I don't see him. Well, at this time we...
Yes.
Oh, go ahead. All right.
Do you hear me?
Yeah, I can hear you.
Okay, thank you. Okay, good morning for some of you and good afternoon for the others. And initially, I would like to thank Dr. Fobi and Dr. Mohit Bhandari for this very kind invitation to participate in this virtual bariatric university program. And at this moment, I would like to welcome Dr. Surendra Ugale from Hyderabad, India, that will talk about sleeve with ileo and duodeno-ileo interposition, bariatric metabolic operations, indications, and outcomes. I'm really pleased to introduce Dr. Surendra Ugale, who is a close friend. He's a very skillful surgeon and innovator, and has contributed to the laparoscopic world since the early 90s, and is passionate about a number of different issues, and especially metabolic surgery. Dr. Surendra Ugale is the director of the Department of Bariatric and Metabolic Surgery at Kirloskar and Virinci Hospital in Hyderabad, and a visiting professor of surgery at KLE University, Belgium, and visiting consultant in Calcutta and Mumbai. He has been passionate about laparoscopic surgery since 1991, having been the very first person to start laparoscopic surgery in South India, subsequently helped spread it to many parts of India and abroad, always promoting a team approach. His team is the second in the world to start laparoscopic interposition for type 2 diabetes back in 2008. And then he trained surgeons in different parts of the world, including Turkey, Georgia, Iran, Mexico, Russia. And he's also introduced a new scoring system, diabetes severity and remission score in 2013. Surendra, please, welcome.
I bring you greetings from Hyderabad, from India. And in these pandemic times, I hope you all have got great immunity and maintain good health and stay safe. And today I'm going to speak to you on this invitation, this kind invitation from Dr. Fobi and Mohit Bhandari of BBU 26 about the sleeve plus operation to do with ileal interposition. So when it is a sleeve plus ileal interposition, this could be of two types. Actually, I'm going to talk of two procedures at this time. Is jejunal ileal interposition, which we use mainly for obesity, and duodenal ileal interposition, which is for diabetes. Next. We are fortunate to have the pioneer of this procedure with us, Dr. Aureo de Paula, who I consider a thinker surgeon, and he has been my teacher, and we both will be exchanging views on this procedure here. Next. Early in his work, Dr. De Paula, he performed a randomized clinical trial, which compared these two versions of the operation. One, as I said, was jejunal, where you take the ileal interposition into the jejunal area, and the other is duodenal. Next. And it was very obvious from the data that he had that the duodenal ileal interposition with sleeve gastrectomy is significantly more effective even in severe situations of diabetes. So following this randomized clinical trial, the duodenal ileal interposition has been a preferred metabolic operation for diabetes independent of the preoperative BMI, while jejunal ileal interposition has been used mainly for obesity with or without diabetes. Next. So you see, if surgeons believe that their patient can be treated with only a sleeve, then it's fine for them to do that. If the diabetes is mild, if the BMI is not much, then this is fine. As the BMI goes up and or the diabetes increases, usually bypass procedures are done in most parts of the world, in most centers. We, as a preference, would prefer to do a sleeve plus jejunal ileal interposition, where you can see here, you do a regular bariatric sleeve, and then you take a segment of the ileum and place it into the proximal jejunal area. This usually is 170 centimeters in length and placed between 20 to 50 centimeters from the DJ flexure. Next. So why jejunal ileal interposition? Because this gets you the ileal stimulation and the ileal break phenomenon that one is looking for. And it is relying more on better incretin response and not on malabsorption as in many of the bypass procedures. Next. The patient selection is as such, the inclusion criteria, morbid obesity with or without type 2 diabetes in age ranges of 20 to 70 with a BMI more than 35. Exclusion are the usual contraindications for any major surgery. Next. This is the diagrammatic version where you can see that the bariatric sleeve gastrectomy is done. In the earlier phase of experience, we did use it for diabetes also, which is why we did the adjusted sleeve for diabetics who had lower BMIs. And then the ileal segment is taken from the terminal ileum, which is 30 centimeters from the ileocecal valve, and interposed in between and the proximal jejunum. Next. This procedure, when we looked at our outcomes, it gave very good weight maintenance even at 10 years. So we are looking at long-term outcomes now. The percentage of total weight loss was 21% at 5 years with a mean BMI of 25.6. At 10 years, the percentage of total weight loss was 16.5% with a mean BMI of 27. So I would say it's a pretty good maintenance long-term. And this was with a follow-up of 63.8%. And we have a data which was published last year. Next. There is a great nutritional stability with this procedure because as you could see from the diagrammatic version, there is no bowel exclusion, there is no bypass. So even at 10 years, there is no need for supplements. It is very infrequent that it may be need-based according to the lab results. They have reasonably good control, where you can see 43% of the patients had an HbA1c of less than 6.5 at 10 years. The control of glycemia with A1c less than 7% was excellent at 10 years, and this took place in all patients. 50% of those needing insulin initially did not require insulin even at 10 years. Next. Next, please. There is a good maintenance of control with the lipids, even up to 8 years, where the triglycerides, the mean was 140, cholesterol mean was 158. Dr. De Paula also has published his data of midterm outcomes of 120 patients with the jejunal ileal interposition with a sleeve, giving very good weight control and control of comorbidities. Next, please. Since there is no bypass of any portion of the GI tract, there is no malabsorption expected, which is shown by these figures of the nutritional components. And supplements were used routinely only for the first year, and later only if any deficiency was found during the follow-up checks. So you can see all the way up to 10 years, the good maintenance of hemoglobin, the proteins, albumin, vitamin D, B12, and iron. Next, please. So I wanted to intentionally start from the simpler procedure because we hear every time that this is a very complex procedure. So it was a sleeve with a segment of the terminal ileum taken up into jejunum earlier. Now we're going to the little more complex version, which is the duodenal ileal interposition. Here, because we are mostly operating on lower BMI patients, we use a tailored sleeve adjusted according to the BMI. And we again transpose a 100 or 170 centimeter segment of terminal ileum, which depends on the length of the small bowel. If the small bowel is less than 400 centimeters, we will use only 100 centimeters of the ileal segment. And this segment is then anastomosed to the pyloric area of the duodenum, because the duodenum first part at the level of the gastroduodenal artery is transected, and the distal end of the ileal limb segment is anastomosed in the proximal jejunum at 50 centimeters from the DJ flexure. So the duodenum and proximal 50 centimeters of the jejunum are the only parts that are excluded and bypassed. And you can see it in the diagrammatic version on the slide. Next one. This is one of the earlier publications of Dr. Aureo de Paula, where he operated patients with BMI of 21 to 34. So they were all in the lower BMI group. And you can see the diagrammatic version again, how the BMI is used to adjust the level where you start making the sleeve. Next slide. So why duodenal ileal interposition? Well, bariatric surgery is available for morbidly obese diabetics, but there's nothing for lower BMI diabetics. So non-obese patients with moderate or severe diabetes, if they have no hope to be without insulin and they have to be continually treated by the endocrinologist, this procedure also addresses most of the pathophysiological aspects of the ominous octet as propounded by DeFronzo. And again, because of practically no exclusion, it's just that 50 centimeters of jejunum. So there is no malabsorption or very minimal, and you're relying more on the incretin response. Next slide. In this study, NHANES 19, which was published 2013, you can see that 80% of the patients with diabetes are in the group that is less than BMI 35. Only 20% of these patients were more than BMI 35. In the data which we have in our experience here, BMI less than 30, we had 54% of our patients, while BMI less than 35, 76% of our patients. So it's pretty close to the international data. Next slide. And that is why the importance of being able to do a procedure for these diabetics, because one of the biggest areas which are the targets are control of the cardiovascular problems leading to mortality. And here you can see in this where all these studies, whether UKPDS, Accord, Advanced, Credit, all of them are showing that you need a glucose control more than 5 years for it to be beneficial to control cardiovascular mortality. Next slide. And that's why the emphasis for the long-term control of glycemia. So the indications for the duodenal ileal interposition: worsening type 2 diabetes of more than 1 year duration, with or without additional risk factors and comorbidities, mainly microvascular or macrovascular. Diabetes with mild to moderate problems like nephropathy, retinopathy, non-healing ulcers. Diabetes with a very strong family history of complications, or poor glycemic control despite optimum medical treatment. We have ages between 20 to 70 with BMI more than 20. And we usually look for a reasonably good post-meal or a stimulated C-peptide response of more than 1.5 nanograms. Next slide. You can see in the exclusion criteria mainly, you must make sure you are not dealing with type 1 diabetes or LADA, which is the latent autoimmune diabetes of the adult, or a diabetic with undetectable fasting C-peptide, because this means that there is a beta cell burnout and this patient is not going to respond to the surgery. Next slide. And we've always believed that a true metabolic procedure should be possible and available for any uncontrolled or poorly controlled diabetic, irrespective of the weight or BMI. Next. One could focus on certain patient subgroups. For example, diabetes with morbid obesity, with dyslipidemia, heart disease, nephropathy or retinopathy, or hypoglycemia because of insulin injections with glucose fluctuations, or uncontrolled A1C in spite of high doses of drugs or insulin. Next slide. And these are the subgroups we could request or encourage our endocrinology and physician friends to consider for this surgery. This was in 2013 where we propounded that we need a diabetes scoring system to assess the severity of diabetes and then make an appropriate choice. Next slide. And there are now multiple, there are about 5 scoring systems available globally. Ours is the only one which has considered patients in the lower BMI group, because the others have all taken patients with BMI usually more than 35 and some with BMI of 30 and above. This scoring system has 7 of the parameters with a simple score of 1 and 2. And then we improve this further. Next slide, where we have added HbA1c, because we realized on data analysis that those with a poor glycemic control, next slide please, had worse outcomes. So the 8th factor was added to see how the control of the glycemia and the current state was before surgery. Next slide, please. The long-term results which have been presented by Paula and his team, where they have follow-up of 8 to 13 years, you can see in all weight ranges, in the normal weight range, overweight, and the obese, the duodenal ileal interposition has given a partial remission at this long term with a mean of 60% without any anti-diabetic medication. Next slide, please. The data that we have published last year with our 10-year experience, where there is a good control of fasting sugars, but it starts to go up after the 5th year. Better control of the postprandial sugars. With a mean HbA1c, you can see from the preoperative HbA1c of 9.4, it's maintained all the way up to the 10th year with the HbA1c of 6.5. The remission rate gradually drops as the years go by. Even at year 8, we had a remission rate of 62.5% and a glycemic control of HbA1c less than 7 with no medicines of 83% up to 8th year. The need for insulin drops in the initial phase, and by the 8th year, it has gone up a little bit, up to 11%. Next slide, please. So the mortality reduction depends on the multiple factors where a long-term control gives you the benefit of control of cardiovascular mortality. So here you can see in the long-term microalbuminuria, control of 74%, weight control in 84%, systolic blood pressure control in 86%, triglycerides and LDL in the 80s, and HbA1c in this long term at 60%. Next slide, please. These were the results from Paula's study. When you compare other procedures in the same BMI groups, this is for BPD, and when you look at the group which is BMI 25 to 30, there was only an 8% remission in that group with the added problem of malabsorption. This was published in 2019. Next slide, please. When the group of patients are outside the criteria of the NIH, that is, the BMI is less than 35, this meta-analysis showed that ideal interposition had seemed to be the most effective operation for these diabetics who do not meet this current NIH criteria. Next slide, please. And when you look at the complications of this procedure, it is quite similar to the other bariatric procedures. The most frequent post-operative problem we found in the initial short term was food intolerance. In this series of 454 patients, these were consecutive patients, which was published by Paula. The 30-day mortality rate was 0.4 and major morbidity of 4.8%. Next slide, please. In the same way, the complication rates that we experience in my work in India and earlier in Turkey, we had a total complication rate of 7.75% and a mortality rate from the procedure of 0.2%, which are all been published. Next slide, please. This surgery of ileal interposition could be done completely laparoscopic. These are the different approaches, which is what we do. But when surgeons are hesitant to do the whole thing laparoscopically due to the configuration changes, the closure of the mesenteric gaps required, they could do a hybrid, which is laparoscopic for the sleeve part and then open for the with the mid-abdominal incision, especially when the BMIs are lower. If BMIs are high, this gets more difficult. So it can be done completely open in diabetics who are very slim, and any GI surgeon can do this. And of course, there's the robotic if one has the facility. Next slide. In slim diabetics, one very important factor we should remember is they cannot tolerate malabsorption. Therefore, they do very badly with any procedure that does a major bypass. And we've realized that ileal interposition with this BMI adjusted sleeve is the best way forward for these diabetics. This is the duodenal ileal interposition. Next slide. This is a publication from Professor Foschi from Italy, which showed that the duodenal or the ileal interposition with the diverted sleeve does not cause biliary salt malabsorption. And similar assessment was done in Brazil too, which showed that the bypass procedures, there was 95% malabsorption. With ileal interposition, there was no malabsorption. Next slide. So this becomes a very important factor. And when we look at the advantages of duodenal ileal interposition, this is a good hope for slim diabetics who don't have good control. There's a nutritional stability without malabsorption. This can be a great rescue operation for any patient of BPD-DS or any other similar bypass procedures where there's severe malabsorption. There is a great deal of benefit on the financial side. We had done this study in Turkey and this was published. We found there was a 90% reduction in the expenses of the diabetes care. Next slide. This was just to show you in outcomes few salient features of some of the patients. This young lady, age of 25, she was operated. So we had to make sure she is type 2 diabetes. BMI pre-op was 31. Currently, after 8 years, her BMI is 23.5 and she is in remission. Importantly, she used to have laser treatment in the eyes every month. And ever since the procedure, retinopathy has resolved and she has no further laser treatment or problems with the retina. Next slide. This is a gentleman of 56 years, pre-op BMI of 24. After 2 years, the BMI is 21. So this is how even in these lower BMIs, there's no excessive drop of the BMI. Next slide. So these few slides were just to give you real examples. Again, patient preoperatively age 24. Again, we have to do all the tests, including antibodies like GAD antibody, islet cell antibody, etc. Check the C-peptides. Pre-op weight, the BMI 29. Now, after 11 years, his BMI is 21. Before, his life was lived with an insulin, with a pump on his waist, like a pager. Ever since the procedure, the pump has gone, insulin has stopped, and there's no anti-diabetic medication. Next slide. This gentleman, preoperative BMI 26.5, and at the end of 10 years, his BMI 23.4. Next slide, please. So you can see how they do really well with this procedure. This gentleman, 9 years after ileal interposition, he has run 11 marathons. He lives in the US in Dallas. Next slide. So with that, I end my presentation and thank you very much for this.
Thank you. Aureo, go ahead. Aureo, do you have any comments?
Yes, thank you, Dr. Fobi. I have two brief and very objective questions to Dr. Ugale. The very first one is, why do you think is so difficult to deliver the message of a metabolic surgery through all different BMIs, even between surgeons? And the second question is, why do you think the results are quite good at 1, 2, 5 years? And why do these people have a worse outcome after 10 years? And the third question is that, why do you think a duodenal switch is so effective in between morbid obese diabetic patients and is very ineffective between normal weight patients? Thank you.
Thank you for the questions, Aureo. And to answer your first one, unfortunately, what we find in real life in society is that most people want to find an easy way out. Everyone wants the simplest, shortest surgery that can be done. Many surgeons also believe that, okay, sleeve can do everything, so they will probably just use the sleeve. Many of the one anastomosis bypass procedures are quicker and more easily done. The ideal interposition, I mean, all of us, we acknowledge, like Mohit said in the beginning, that you've done amazing scientific work and a lot of thinking on the metabolic front in developing this procedure. So honestly, one looks at science, one would love to do this procedure, and the only thing that holds people back probably is a fear and an inertia, thinking that they may not be able to learn the procedure well. So maybe they need opportunities for training, they need opportunities of exposure, and to be made to understand that when they are skilled already in doing a sleeve and any bypass, this is just a little more of that procedure. But the biggest advantage is that we give the patients the advantage, which is lifelong, that they don't have malabsorption. And that, I think, is a big factor which surgeons should seriously look at. And that's why these days we have been encouraging younger surgeons, and even in the medical institution, the teaching institutions, that if you wish, start with slim diabetics, the low BMI diabetics, you do it open if you want. If you have a hesitation about the anatomy and the configuration and the mesenteric closures. To give an example now, how many surgeons, even to this day, when you do a OAGB or you do any other single anastomosis, they close the Peterson space. They are slowly increasing, but so many surgeons have been reluctant to close Peterson space. So you can imagine, yes.
So Dr. Ugale, so what you're saying is that the reluctancy in relation to the message of doing a metabolic operation to all BMIs relies on the technical issue?
I think there is an inertia initially of embarking on a bigger procedure. So if they are exposed to these procedures, if certain hand-holding is done, they will become really comfortable in this, especially when they see the advantages that the patients have lifelong. And which is why I think in teaching institutions, they can even start doing it open to overcome this, this trepidation or anxiety of doing so many anastomoses and the mesenteric closures.
Okay, Dr. Ugale, thank you. And the second question has to do with why do you think these people, you know, as after in a long-term follow-up, the results are not as good for all types of surgeries?
You mean in the other?
In the metabolic specifically to the metabolic operations, why do we see very good results early on in the follow-up, and the results are not as good as the long-term follow-up comes?
So
your insight.
So it seems to be clear that if majority of the points in the pathophysiology of diabetes are not addressed, one is likely to have a recurrence of diabetes. In some of the operations, it was dependent more on weight control. And when there is some amount of weight regain, they relapse. In so many other instances, any infection in the body, any stress that a patient has makes them very labile, and they immediately show up with recurrence of diabetes. And malabsorption, whenever it is there, is such a big factor that this in the medium term and the long term is bringing about a recurrence of diabetes. So these, I think, are the various factors. Would you like to add some more to that?
No, I think at this time we would move on so we can at least give Dr. Melissa a chance to make his presentation. So, Dr. Fried, could you go on? Thank you very much.
Thank you.
Aureo and Surendra.
Thank you.
Thank you.
Okay. Good afternoon, morning, or evening, wherever you're sitting. I would like to thank Mohit and, of course, Mal for inviting me to this excellent session. It's my honor and pleasure to introduce John Menssas, who is currently the Director of the Department of Bariatric and Metabolic Surgery, ISO General Hospital in Athens. And he's a long fellow and a long, very active part of IFSO, which he joined in 1996 and served as the president of the 6th World Congress, which was held in Crete. And he was then elected in 2006 as a president of IFSO, and he's a member of the board of trustees of IFSO. He's also serving as a director and scientific board member of the European Accreditation Council for Bariatric and Metabolic Surgery. So this is just briefly to add a few sentences after Mohit already introduced all the faculty and the panel. And again, John, please, if you can introduce us to your lecture, which is entitled Sleep with GI, Anastomosis, a Bariatric Metabolic Operation, Indications and Outcomes. So please.
Hi, I'm Professor John Menssas, Director of the Bariatric Unit at the University of Crete, Greece. My university is on the island of Crete in the city of Heraklion. Cretan citizens used to be thin and healthy from the ancient times until very recently. Unfortunately, the westernized way of life, followed by the population, the last decades, led to a dramatic increase of obesity and cardiac and metabolic diseases. This is why at Heraklion University Hospital, there is an increasing number of operations for morbid obesity every year. We have performed all types of primary and revisional bariatric operations and some new investigational procedures such as sleeve gastrectomy plus jejunoileal anastomosis. Why sleeve plus jejunoileal anastomosis? Because it was known from previous studies that best results in weight loss and the remission of comorbidities was achieved by Roux-en-Y gastric bypass and by biliopancreatic diversion. Both procedures are diverting food and biliopancreatic diversions to the distal small bowel. Therefore, it was estimated that by bypassing a significant part of the small bowel with a jejunoileal anastomosis, a degree of malabsorption would be achieved. Additionally, fast transit of food into the distal small bowel will stimulate the L cells of the terminal ileum to release GLP-1 and PYY, along with normalization of beta cells function and reduction of resistance to insulin. This is the procedure schematically. Sleeve gastrectomy, 100 centimeter small bowel from the loop from the ligament of Treitz, and 200 ileal loop from the ileocecal valve, side-to-side isoperistaltic anastomosis. In order to investigate the feasibility of a side-to-side jejuno-ileal anastomosis and its ability to control diabetes, this procedure was first performed in diabetic rats. 17 animals allocated into 3 groups: jejuno-ileal anastomosis, side-to-side sham operation, and control animals without operation. Here is the anastomosis in the rat. The animals in the jejuno-ileal anastomotic group had progressive weight loss until the 28th postoperative day. Animals in the control group and some operated animals had no weight changes. Fasting glucose levels in the jejuno-ileal anastomosis group were significantly reduced during the whole postoperative period of observation. Animals in the other 2 groups had their glucose levels unchanged. Following the animal study, the procedure was performed in morbidly obese patients, as shown in this slide. Sleeve gastrectomy is performed at first, followed by side-to-side isoperistaltic jejuno-ileal anastomosis using 100 centimeters from the ligament of Treitz and 200 centimeters from the ileocecal valve. Originally, in the early stage of our experience, 100 centimeters from Treitz and later 150 centimeters were used. But this ileal length was abandoned due to hypoalbuminemia seen in a number of patients. 6 trocars are used, 5 are the same as used for simple sleeve gastrectomy, and so 1 extra 5 millimeters trocar in the lower quadrant. 2 monitors are necessary for this procedure. And as decided during the World Consensus Meeting for Standardization of Bariatric and Metabolic Procedures, held in New Delhi in India, March 2018, which was organized by Dr. Fobi and Dr. Bhandari Mohit. The sleeve excision line starts 5 centimeters from the pylorus and ends 2 centimeters from the esophagogastric junction. By this excision, the volume of sleeve is approximately 150 cc's, which is important for the intake of proteins. This is the closure of the defect among proximal and distal small bowel loops. Patients remain 3 to 4 days postoperative in the hospital, and the gastrographic follow-through is performed on the 3rd postoperative day. 100 patients were operated with sleeve plus jejuno-ileal anastomosis, 22 males and 78 females with a mean age of 37.5 years and a mean BMI of 46.88. 28 patients in this group had diabetes, 32 had hypertension, 34 dyslipidemia, and 38 sleep apnea syndrome. 338 patients with sleeve gastrectomy performed the same period of time, served as control, from which 66 were males and 272 females. Mean age 35.4, mean BMI 45.6. 78 patients in this group were diabetics, 81 had hypertension, 104 had dyslipidemia, and 139 sleep apnea syndrome. Therefore, both groups were very similar in demographic characteristics and the incidence of comorbidities. Patients were followed up from 39 to 60 months with a mean of 46 months. Weight, comorbidity, outcome, early and late complications were carefully recorded. Operative time in the plus group, 85 minutes, more prolonged than the 58 minutes for sleeve gastrectomy, something that was expected. We had no mortality. Early post-operative complications were minimal and easily treated. Gastrographic follow-through performed at the third or fourth postoperative day show that there is much increased time after sleeve gastrectomy, transit time of the food from the duodenum to ileocecal valve. Following sleeve plus, it was a mean of 11.8 minutes time from transit of the gastrographic from duodenum to ileum to the ileocecal valve, while in sleeve gastrectomy alone takes 31.1 minutes. Late postoperative complications were few and easily treated. 4 patients in the early period of our experience developed intestinal obstruction due to internal hernia. In 1 patient, an isoperistaltic anastomosis was associated by nausea and anorexia. In 6 patients, in the first period of the study, with a shorter than 200 centimeter ileal loop, developed hypoalbuminemia. In all patients, the anastomosis was reversed successfully and the complications were treated. As far as weight loss is concerned, there is significant difference already obvious from the 6th postoperative month in favor of sleeve plus group. 59.9, the excess weight loss in the sleeve plus group, and just 50% in the sleeve group. The same statistically significant difference is observed at the 12th postoperative month. Most importantly, the duodenum to cecum transit time, as mentioned earlier, is very much shorter in the sleeve plus group, 11.8 minutes versus 31.1 minutes. At 24 and 48 postoperative months, the weight loss is significant more in the sleeve plus group, 72.9 versus 59% at 24 months, and 70.5 versus 58.6 at 48 months. Significant differences in favor of sleeve plus were also observed in terms of improvement of or complete remission of obesity comorbidities. For diabetes, 85.5 remission or significant improvement in the plus group as early as 3 months postoperatively, and just 50% in the sleeve group. For arterial hypertension, dyslipidemia, and sleep apnea syndrome, similar results in favor of sleeve plus were observed. The same results were observed for all obesity comorbidities in favor of sleeve plus at 24 months. 82.1 improvement in remission of diabetes versus 71.8, and so on for the rest of the comorbidities. At 48 months, similar results were observed in terms of remission of obesity comorbidities in favor of sleeve plus. In conclusion, sleeve plus jejunal anastomosis improves weight loss compared to sleeve gastrectomy. It improves or resolves obesity comorbidities in a greater extent than sleeve gastrectomy, particularly diabetes type 2. Therefore, it may be used as primary bariatric operation or as a revisional procedure to improve weight loss after an unsuccessful sleeve gastrectomy. Most importantly, this study proved that the sleeve plus jejunal anastomosis is a simple, safe, and reversible procedure. And always, when you practice something new in medicine, you should remember the teaching of Hippocrates. First and above all, do no harm. Thank you.
Thank you very much, John, for this presentation. It's indeed very interesting to hear that we embarked independently on very similar procedures. The thing what we did in Prague, and we are still using this operation, is that we perform the anastomosis without a sleeve gastrectomy. Just leave the anatomy as it is and just perform the side-to-side anastomosis. But this is a different story. I'm not going to talk about our procedure. What I wanted to ask you, did you measure or quantify what portion of the food goes the normal anatomy longer way and what portion of the food goes the, let's say, shorter way?
Thank you very much, Martin. I think, as you said, we also used recently, well, quite recently, simple jejunal and anastomosis, particularly to treat diabetes patients in non-obese patients from BMI 25 to 32. So it's a very good point that you made. Now, we try to actually quantitate the portion of food that going straight from the loops to the ileocecal valve with using nuclear medicine. And we haven't published anything, but 80–85% of the total food goes straight to the shorter route. We prove that using nuclear medicine techniques. We haven't published anything because we haven't finished that study yet. It's still on the way. But as I said, if you do a barium study, if you do a gastrographic study, you can see with your eyes the dye going straight to the ileocecal valve. Very, very short period of time comparing to the long period of time that takes after sleeve gastrectomy.
Yeah. Thank you, because we have got a very similar results. We have got a little lower, let's say, percentage. We have about 60% going the short way and 40% going the original long way. However, the anastomosis is patent even after 3 years after the procedure. It does not close the enterostomy. So that's one thing. The second thing is that what we really fear is basically, quote unquote, the only thing in the whole operation in the longer term, and that's the internal hernia. So how do, of course, we close the mesentery whatever we can and whatever possible, but due to any special closure of the mesentery, I realize that you have about 4 cases of internal hernias, but how do you treat that? I mean, not the internal hernia, but how do you try to prevent the internal hernia?
The more experience you have, the better you are in closing the defects. As you said, it's a big defect between the 2 loops. So if you don't close the defect very, very carefully, you face an internal hernia, and you have always the fear of patient developing and come back to you with internal hernia. In this case, in the 4 cases, we reverse the anastomosis to solve the problem. But as you gain experience, it's better the closure of the defects.
Yeah. Okay, well, we have got very similar approaches because we use this operation for lower BMIs diabetic patients, and the results are very, very similar. So anyone from the panel has got any other question to John?
No, I think we have had 4 interesting lectures that stresses the physiologic aspect of the bariatric operations we do. At first, we used to talk about restriction and malabsorption, but it looks like we're dealing with endocrine inhibitors that controls the weight and the diabetes. Dr. Bhandari is in the room. I told him to go ahead and start the case, and he will just tell us what he has done, and we'll go from there. But I'll have the fellow or the junior consultant present the case to us, and I'll ask all the panelists to stay and ask questions or make comments while Dr. Bhandari operates.
आवाज तेज करो, सुनाई नहीं दे रहा कुछ भी मेरे को.
Okay. You're live. Mohit, you're live.
Today we have a 27-year-old female with a height of 145 centimeter and weight of 99.4 with a BMI of 47.3. She's a non-vegetarian by diet, no addictions, and she has hypertension and osteoarthritis along with OSA as comorbidities. Her blood profile is within normal limits, with HbA1c being 5.8, albumin of 4.2. All the viral markers are negative, including COVID-19, and her USG showed grade 2 fatty hepatomegaly. I'll ask to take over to the operation theater. Thank you.
So, good evening, everybody. Dr. Fobi asked me to complete the case because we have already exceeded our time by almost 45 minutes for the entire show. One of the lectures was 25 to 30 minutes. So I thought that maybe I should try to compensate for the time. So this is our port position. We did a sleeve with bipartition here in this surgery. So this is a optical port which is just above the umbilicus. There are 2 12 mm ports in the anterior clavicular line, just in line with the optical port. And there are 2 5 mm ports in the subcostal area, 2 finger breadths below in the anterior clavicular line. I'm standing on the right side of the patient. I have an assistant who is standing between the legs of the patient. Can we have the internal view? So this is the internal view. As you can see that we have made a sleeve here. The sleeve has been calibrated to a size by 38 French bougie. We made an anastomosis of size 4.5 centimeters with 180 centimeters of the bowel. The distance we leave from the pylorus is around 4.5 to 5 centimeters, so that we do not make the anastomosis with this thick antrum, which is difficult to manipulate and do the anastomosis on because of thick musculature here. This here is the pylorus. That's the first part of the duodenum. And as you can see here, almost a distance of around 5 centimeters. This is the anastomosis, and that's a sleeve. This is 180 centimeters. So this is the afferent and this is the efferent limb. I have not counted the common channel because what we do here is a loop DJ bypass with bipartition. We do not keep 300 or 200 centimeters of a common channel. And whenever we take combined length of bowel less than 200 centimeters, we, as a rule, do not count the entire length of the bowel, because by our experience of mini gastric bypass, we feel that that's the adequate length of the bowel, which does not cause malnutrition if we are below 200 centimeters. So I'll do an endoscopy and demonstrate the bipartition nature of this surgery and how we expect 30% passage through the pylorus and around 70% passage through this particular anastomosis. So can I have the endoscopic view? So you can see this is the esophagus. A little bit of blood in the esophagus just because we did a fresh anastomosis, so we expect that. That's the G junction. As you can see, the Z line. So I'm putting a little bit of air here at the Z line, just when I'm at the Z, so that I don't need to put more air when I enter inside. Now, this is the tube, the sleeve tube which I created. Now, beautifully, you can see that this is the anastomosis which I made. So you see, the food is going to directly go into this, and it would drop as a mechanism of around 70%, because the kind of anastomosis we make is always anterior anastomosis. So you see here, you can see in the PIP that I make an anterior anastomosis, and that's the reason why we have the food directly falling into this particular area here. Now, if we go further beyond here, we would see the pylorus. So I would go further beyond. So this is the pylorus, as you can see, and I can actually negotiate my way through the endoscope into the pylorus. So I can see both the openings. So this is the retroflex view. I'll pull the scope. So here you can see the pylorus. And if I go a little back here, so here you can see the anastomosis. So now for the food to go into the pylorus and cross this area here, there's a little bump which we created. So you see this bump which we created here will, now this is the view which I wanted to demonstrate. So this bump which we created will let only 20% of the food go into the pylorus, and the food is going to drop straight away into this anastomosis. And here, this is one of the loops, and this is the other loop. So this is the afferent loop, and this particular loop is the efferent loop. So you can see both the loops here, and then you see this bump here, and then you see the pylorus there. So that's what I wanted to demonstrate. Thank you very much. If there are any questions, I'll be more than glad to answer. The procedure took us 12 minutes as an operating time and 5 additional minutes to put the ports and remove the specimen. So 18 minutes to perform. Thank you very much.
Thank you. Tarek, you have any comments? Or you've gone to surgery? Dr. Mandy?
Yes, Dr. Fobi is very nice. Almost always Mohit is unique. He finished it in a very short time. And this is the story, really. When we ask ourselves at the end, why we are going to exclusion, and if you have the same results with bipartition, why we are going to exclude a lot of small intestinal with all of this complication of this excluded part, and we have the same results with bipartition? This is my question for all our panelists. Why we are going for exclusion?
That is a good question. You know, most of us surgeons are like goats. They eat around the tree where we're tied to. So most of us do what we are exposed to. But the question I'll turn back and ask you, Tarek, after watching Dr. Melissa perform the jejunal bypass with the sleeve, I see that he's using your principle of endocrine restriction, stimulation of GIB, and then ilia stimulation. Why would you not just do what he does?
Yeah, you are right. It is the same. It is the same concept. No exclusion. We need to bipartition. But maybe the problem with Dr. Melissa, it is so difficult operation, and we have a high instance of internal herniation. This is a problem with this technique, but it is the same concept. It's bipartition. You push some food to the ileum because the problem is the ileum. The problem is the ileum. If you stimulate the ileum, if you stimulate L cell early, you will make balance between the upper and lower gastrointestinal tract secretion. It's very nice operation, but maybe the problem of this operation, it need more and more experienced surgeon, have a long curve, learning curve, and also the problem with the internal herniation. This is a big problem of this operation, but they have the same concept of bipartition.
Any of the other panelists has a question of Dr. Bhandari or any of the speakers or a comment?
Can I ask a question of Dr. Mandy and maybe other surgeons also, Dr. Fobi?
Go ahead.
That do you find a great individual variation? Because we have seen patients having same bowel lengths with an OAGB, the same bowel lengths of a SASS. Some patients are completely fine nutritionally and with their result, while there are other patients who actually go into nutritional cirrhosis with malabsorption, they get ascites, and they have to be reversed or partially reversed. Well, one advantage of SASS, as Dr. Mandy pointed out, is one stapler firing and you retain the sleeve, but you disconnect the bowel anastomosis. That, I think, is an advantage with a procedure like this. Whereas in an OAGB or RYGB or anything else, you would have to do a lot more and you will not have something in place. So patients regain their weight. So do you find a lot of individual variation like this? Because we have seen this happening across the board.
Yes, you're right, 100%. For this reason, we'll make a standardization of our technique to avoid the complication, because our aim not to divert the food, our aim to just stimulate the ileum. So we need some food only to stimulate the ileum. And about easy exit strategy, you are right. It is first, it is the right of our patient at any time to ask you to convert it to the normal anatomy. And sometimes your patient, he don't like this operation. He feeling something you can't explain for him. He feeling pain. At 10 minutes, you can convert it to the normal anatomy. About the weight regain, you save your patient. If you have a patient with severe nutritional deficiency with liver cell failure, the problem now is life-saving, not to weight regain. So it is easy to save your patient. And I think nobody can think about the weight regain or weight loss at this time. you would save your patient. So it seems to be as a normal physiology at any time. You can convert, you can stay, you can manipulate according.
Okay, I think he's having a
Wi-Fi
Wi-Fi problem
of your patient. If you have a body mass index 30, and yeah.
Okay, now let me point out something from experience. That
if you have a patient with body mass patient with body mass 30 with diabetes, you can manipulate your stomach according to the body mass index. This is completely metabolic operation. We are using the physiology to manipulate the obesity and diabetes.
Okay, and
Dr.
any of the other faculty members have a comment? Mohit, you do routine pre-operative endoscopy, intraoperative endoscopy, right?
Yes, we do it for all our cases.
And what would stop you? How would that affect what you do during the surgery? Do you change the procedure if you make any findings?
Yes, so we, as we always explain in all our, so I have done a pre-operative endoscopy here also. We always do it in all our cases. And the reason why we do not do it before is just to have more patient convenience and avoid any sort of loss of patient from the program, because most patients who get a pre-operative endoscopy in our cultural setup, they are not very happy what we realized. This is a very different practice and very very controversial, you can say, but we don't do pre-operative endoscopies. We do intraoperative on-table endoscopy after induction of the patient. But having said that, we take a very general consent that we can change the procedure if we, for instance, find a large hiatus hernia, we might convert that from a sleeve to a bypass. Or if we find a duodenal ulcer, in those cases, a gastric bypass patient might be converted to a sleeve. If we find a duodenal polyp or a gastric polyp, the frozen section facility is available and we might cancel the procedure. There are certain disadvantages of the procedure, whereupon if we have something malignant, the patient gets the GA and then we have to change then we have to abandon the procedure. But even the preoperative endoscopies where we were always doing it under general anesthesia, giving propofol. So we are happy with this kind of practice, and we have a lot of data on that. And we have always presented that data on forums where it need to be presented.
Was there any reason why you chose this particular patient for the modified SASS procedure? I noticed you did a SASS, but you did it with proximal gastrojejunostomy.
Yeah, we do SAJI basically. We never do SASS here in our practice. We always do a SAJI, which means that we bypass just 180 centimeters, which is a modification of SASS. This patient was chosen for either MGB or either SASS, whatever. But why I did not do an MGB? Patient has a BMI of 50. But why I chose doing SAJI instead of an MGB is because we know that SAJI will have around 30% of the food passing through the pylorus, which can decrease iron deficiency for this patient who is a young female. She had a very bad metabolic syndrome and bad metabolic disease. But mini gastric bypass in young females, specifically super obese, my experience is that complete exclusion of duodenum causes a lot of iron deficiency and anemia. That's why I chose a SAJI instead of a mini bypass here.
Okay. Dr. Fried, do you have any comments? You've had experience doing the gastric bypass, the BPD, gastric partitioning, gastric plication. What comments can you share with us and the audience?
Oh, I fully understand, and I'm happy with what Mohit showed us in the OR with the patient. However, on the and I would like just to echo that the partitioning seems to be the way where to go, where you and I'm not talking about the procedure that Mohit now performed, but in general, for example, when we perform the partitioning or whatever we call that, without even touching the stomach. And when we indicate for that patients who are, let's say, up to the BMI of 40 max, so then it works perfectly okay as a purely metabolic procedure. Having or looked at the whole presentations today, and having seen the number of procedures, not just presented today, but the number of procedures we are having in our, let's say, list of potential operations, then I would say that probably we may try to switch our minds to, let's say, rather than in trying to find out new and new modifications of the procedures, rather than to try to find out the best patients for the existing procedures. You know what I mean? Because we are modifying the procedures this way and that way, and we are measuring different lengths of the bowel. And I think that if we use the existing procedures, okay, and try to, let's say, classify the patient and cluster them and assign them to, let's say, certain procedures by their characteristics, which I fully agree, it's a very, very difficult thing to do. But on the other hand, let's say the teams are very experienced in the centers, so they can try to do so. That's, I think, so one of the ways where to go. Because there was a beautiful survey done in Europe that a significant number of potentially bariatric patients are terrified and do not accept the most aggressive procedures from the beginning. And that's because, with all the respect, we can apply to the patient really a very complex procedure with, of course, some higher risks of complications, but the patients are not willing to go for that. And even probably more important, even the referring specialists, other than surgical, are hesitant to refer the patients to the most aggressive procedures. So once we have, if possible, a kind of a clustering of the patients and say, this seems to be the best procedure for you, and the other procedure is best for the other patient, I see this kind of as a future of bariatric metabolic surgery.
Dr. Safadi, you do a variation of procedures. What would be your comment? Do you have an algorithm for the patients, or you?
Yeah, well, my experience in bipartition is practically nil. So I really cannot comment. I've listened with a lot of attention and care. I'm still perplexed as to the power of the distal ileal brake. You know, I'm not really sure where it stands. You know, people have done gastrojejunostomies in the past or gastroileostomies in the past, and those did not really produce much in terms of weight loss. So here we're adding the sleeve on top of that. The picture is becoming confusing. I think it's right time to do randomized prospective trials to compare these procedures and focus on the advantages and disadvantages. Just like Dr. Martin just said, maybe perhaps what we can do then, develop algorithms to pick the right patient for the right procedure, or vice versa.
Aureo, when you do, would you do a sleeve with an interposition in a morbidly obese patient who is not diabetic?
Okay, thank you, Mal. You know what? You know, I've been in the field the last 18 years. And echoing some of the comments that were just made, you know, it seems endless, this discussion on techniques. Second, it seems that we all have pathophysiologic justification for all different surgeries. Number three, it seems clear to me also that we are in between Harley-Davidson fans. And we will have to face the discussion on how to, you know, to extrapolate our assumptions on how to treat diabetes. And finally, it seems very clear for me today that we can find everything in the literature. So now we have prospective randomized controlled trials saying that all of these operations are good. And so with all these things in mind, I think that the very first step is to understand that diabetes is a complex disease. Number two is that diabetes is also a variable disease with multiple phenotypes. And number three, we all have to recognize that the response to the different operations has also to do with the different types of diabetes. And number four, we have to understand that we have to hierarchize. We have to have hierarchy in between the severity of this disease or the different types of operations that we will need to do or to give to these people. So my suggestion or my proposal is that we have to first try to recognize the different people or the different patients or the different diabetics and try to cluster them in the very difficult or the very different type of diabetes and offer these people these different operations. So I think that the end point or the very first answer to all these questions is simply to try to concentrate the different operations to one specific type of diabetic patient. Thank you.
So you tailor the operation to the patient. Fantastic. Well, we have a webinar coming up in July. I think it's going to be the 18th or 19th of July on treatment of diabetes surgically. And I think, Aureo, you'll be part of the panel in that, and we're going to go into some more detail. Yes. Dr. Kasama, I have one last question for you. It was interesting to listen to you talking about bile reflux in the duodenojejunal anastomosis.
Yes.
Because most of the people who do any duodenojejunal anastomosis say the beautiful thing about the procedure is it eliminates bile reflux.
Yes, I agree that these things of the duodenojejunal anastomosis is prevents bile reflux to the stomach. But I found some patients who are suffering from bile reflux after loop DJB in Japan, and then we need to convert it to Roux-en-Y in some number of patients. So that it depends on the patient, it depends on the technique, maybe, but we have to pay some concern about bile reflux may happen after loop reconstruction. Even we thought we preserved the pyloric ring.
Well, I absolutely agree with you. I was just impressed because you're giving us objective data, and people stand up and talk authoritatively about any duodenojejunal, duodenal-ileal or duodenojejunal bypass eliminates bile reflux. I know it is contrary. The problem of bile reflux has to do with either the patency of the pylorus, and when you have the MGB where there's no pylorus, it is more common.
Right.
And so just diverting the bile about 2 feet or 2 centimeters before it gets to the duodenum, and if the pylorus is not functional, you're going to get gastric bile reflux. And Dr. Bhandari has talked about it. The advantage when we used to have these courses was that we invited surgeons to operate. And we had a few surgeons who did a duodenojejunal, duodenal-ileal anastomosis. And for all practical reasons, they could not maintain the pylorus because that area is so short that by the time you do a 2-layer anastomosis, you're right on the pylorus. But that'll be interesting. Mohit, I know you're trying to close up the case. Do you have any comment? And then we'll call this a quit. We are 25 minutes longer than planned. And you have to pardon me, but each one of these talks was good enough to just be one session. And I think I overdid it by putting 4 talks into one session. So I would have to apologize to the audience and to the faculty for rushing you through. But in the next time we do invite you, we're going to make sure each one of you has a forum because there are some very interesting things you said. Go ahead, Mohit.
No, thank you very much for making it. I think it was a very interesting session and learned a lot from it. And I hope that the next diabetes session is more interesting with Aureo and everybody else. Thank you very much. Thank you.
Thank you. Okay, but Himanshu, you have a promo for the next course? If you don't. Thank you. The lecture has been recorded and you can find it on the Mohawk website. We've had a total of 27 webinars and they're all on that website. You can always go there and check it out. And we see you all in a week. Have a good day. Bye-bye.
Thank you.
Thank you.
Yeah.
Thank you.